just get started on some of the intro remarks and that we want to begin with before we start the actual program. So I just want to say welcome to everyone to our Employee Oncology Management Learning Collaborative webinar today. This is actually the third program that we've had on this very, very important workshop that we've offered to our members. And we're doing it in conjunction with the Houston Business Group on Health. So I want to welcome Chris Giesick as well as the leader of the Houston Business Group on Health, and he'll talk about some of the things coming up for him as for the Houston employers. And so we're actually delighted. We have 62 people registered for today's webinar, and a number of them are from the Houston area, employers from the Houston Coalition, and then many of you are from the Dallas-Fort Worth Business Group on Health. So this is really going to be a very, very powerful learning opportunity for employers all across the state of Texas, well, at least in Houston and Dallas-Fort Worth. And so we held the first two seminars workshops were held on June 17th. That was an in-person program. And then again before that, we had held it, when did we do the first one? May, I think. And then we held
May 7th and 8th.
Okay, thanks. And then the second one was online like this as a webinar. That was on June 17th, and today is our third one, as I said, on today's webinar. One of the most important things before I introduce our speaker, who has been here, this is her third time, let's go forward and see some of the things that are coming up for the Dallas-Fort Worth Business Group on Health. You can get your calendars out, and please mark down August 21st for our general membership luncheon, which will focus on something having to do with oncology as well, which is cell and gene therapy strategies and putting precision medicine solutions to work. So, and then that's sponsored by Johnson & Johnson. And then the next one coming up is the Power of Wellbeing Fall Symposium. We started doing fall symposiums about 4 years ago. And this will be on September 17th, the afternoon of that day, 12 o'clock till 5. And there'll be 4 or 5 sessions that I think you'll find very interesting on well-being, mind, body, and purpose. The next program is our big annual forum that is called, every year we come up with a different theme. And last year it was disco, and I think you saw me with my white go-go boots on and my broken wrist. And others wearing their costumes. But this one is Wicked Benefits. The new Wicked second movie is coming out this fall, so we're tying in with that. And so we're thinking about themes for that and participating in that and what you're going to wear there. December 17th, that'll be from 7 in the morning till 6 at night. A big thank you goes to Genentech, who is sponsoring this particular workshop that we've had, the 3-part workshop. And also for Merck and Pfizer, who are our perennial year-round sponsors. And so we appreciate their support. We could not do this without their support for this. So we definitely appreciate that. And then Chris has an upcoming program. Do you want to talk about that, Chris?
Yes, thank you. So we have several upcoming programs, but I only want to highlight one here today because it is directly connected to our topic. And it's an integrated approach to women's health from hire to retire. And it's going to be in person at the Friedkin Group. Those from Houston in our audience know what a great venue that is for hosting a program. But one of the topics we will be addressing is cancer screening and the value of it, and what we have learned and what we can learn from a knowledge of cancer screening. We're also going to be addressing maternity and pre and post menopause challenges that employers and their female workforce face. So that's going to be again on September 10th. You're getting our emails if you're in the audience here, and you can register for that. Of course, no cost for employer members. So I just wanted to mention that. So thank you so much.
Sounds very interesting. So thanks for sharing that information. I do want to add that this program has continuing education credits. It's approved for 1.5 hours on HRCI and SHRM CE credits, and these are the numbers that we're offering that you can use to apply for those credits. And I'm going to introduce Karen Van Khalil. Again, we have done it two times before. Many of you have heard her wonderful presentation on the employer guide and insights for oncology management. But I also want to add that, as you well know, and probably the reason that you're joining us today is because cancer is the number one cost driver for employers, and it's just going to keep on getting more and more expensive. So oncology expenses are expected to rise 30% in the next 3 years. It's not going away. In fact, it's affecting more and more people, and there are many ways to try to forestall the long-term cost expenses by starting at the front end, which Karen talked about in the first session that we did in person on cancer prevention, screening, and then the second one was on diagnosis, treatment, and care and management. Today, she will talk about survivorship and return to work and paying for care. So Karen is the leader of the Florida Alliance for Healthcare Value. It's a wonderful large coalition that deals with the whole state of Florida. And she is absolutely a leader, not only on the board of directors of the National Alliance, which leads all the coalitions, but also for many of the topics that we are learning, especially this cancer one that she and the Midwest Business Group on Health put together for use by all of the employers across the country. So we're happy to bring this to the Dallas-Fort Worth area and the Houston area. Karen, would you like to take over?
I will. Thank you for all the kind words, and hello again. Hopefully not getting too tired of hearing my voice. You've got another hour and a half ahead though. So anyway, so as Marianne said, we had the in-person sessions and then wanted to be able to kind of deep dive on the different topics that we have in the employer guide. Diana, I wanted to check, are you going to drop into the chat at any point the two-page placemat? I should have asked you that when we had our few minutes before the call.
Yes, I can do that. I'll do that
Okay.
in the middle of the presentation.
Okay, great. Thanks. So I'm not sure for the folks who are online today, if you joined us in person, either in Dallas or Houston, or for that first webinar that we had last month. So just to those events, or if you were not, why did we do this project? Well, we had in Florida in particular, when I came to the Florida Alliance, which was in 2011, cancer was already the top spend in Florida. I know the business group on health a couple years ago, that national group said, and now cancer is the top spend for employers. And we were like, wow, now it is. And what we attributed it to in Florida is that we have very, very high prices. We are, the RAND study has us in that #1 spot for most expensive for hospital services for employers. But we also have very high prevalence in Florida of cancer, and also even all those years ago, 14 years ago, late stage diagnosis. So that's what put it up in that, top spend position. So really literally day one of work, jumped right in to work on issues with our employer members. So going back that far, but the more recent why did we do this is there were a lot of um, organizations that were working on employer guides and checklists. The National Alliance of Healthcare Purchaser Coalitions, and we were involved with them. They had a deep dive oncology modules. They did checklists. So did the National Comprehensive Cancer Network that had an employer advisory group, and they created a checklist for employers as well. Community Oncology Alliance, the National Cancer Treatment Alliance, that's a spinoff from them, did a biomarker toolkit for employers, and all of this work, all of it was excellent. But what our employers said was, I don't know where to go for what. It's a lot. So Cheryl Larson, who is my counterpart at Midwest Business Group on Health, and I talked and said, could we do a one-stop shop and create an employer guide that pulls together this great work that at least these three nationals had done and some others that we've since learned. But also, we heard from our employers who wanted to hear case studies. They wanted to hear employer insights. They wanted to be able to see that someone has been able to have success. So we said, when we do this employer guide, we need those insights. So that's a little bit of the history of it. So anyway, just wanted to give that background, and also, a big thanks in particular to those three groups that included both MBGH and Florida Alliance and other coalitions in the putting together of those resources. So a lot of this has, been covered so many times, but I think we all know that cancer is very complicated for anyone to navigate. No matter how steeped in healthcare we all are, we know that it's challenging. The price is, obviously prices continue to go up, especially on the drug side. We've found also that as healthcare systems continue to buy up physician practices and buy up imaging and labs, those facility fees get slapped onto the services that are provided. So that has driven up costs. We also see a lot of variation in how cancer patients are treated could be from region to region, could be within a region, could be from one provider in a practice versus another. They're not all adhering to evidence-based best practice, and they're not all having the same outcomes. Lots and lots of billing errors, whether they tip into the fraud category or not. Some do, some are genuine mistakes, but for some of our employers, they were finding that 90% of their claims had at least one error in them. So something to keep an eye on. Already mentioned how overwhelming cancer is to navigate. We wanted to be able to talk about some solutions there. We already know how fragmented, and there are a lot of delays. Some of the delays employers can do something about. So these were some of the issues that we wanted to cover. Next slide, please. And the financial piece for the employee, for the plan member. This was kind of a staggering data point for us, that 1 in 3 cancer patients enter bankruptcy. And we wanted the employers to understand that and to be able to see what they could do to prevent that from happening. Something that we also were finding when we were looking at the data in Florida, we had, I think it was 7 employers in the Central Florida area over several years of data. And you could, when you would follow the patient through what you would call the episode of care, you could see after like 3 or 4 months that everything changed again. All the tests, everything was repeated, and a completely different course of action was taken. So we asked a lot of questions, and we found out that it's a very high percentage of patients who are initially misdiagnosed, or they're not on the optimal treatment plan that they should be on. So that was an area that we said, all right, how can we assure that the folks are getting the right care at the right place at the right time, and so on. A lot of patients don't seek second opinions. That's an area that needed some boosting for sure. Also, in looking at the data, a majority of expense was being, for those patients who did not survive their cancer, a lot of extreme measures taken in the last 2 weeks of life in the hospital. Social determinants of health, big factor in cancer as well. We've already talked about the bankruptcy piece, but there are other issues. People might live in a food desert. They may not have good transportation to get where they need to go. So looked at that as well. Something that really jumped out at our medical director all those years ago when he looked at the data that we had was that there was not, I think we had 7,000 cancer cases in that data study that we did. There was not one single claim for mental health counseling or support. And we knew intuitively, actually, anecdotally, that people are depressed, stress, anxiety, and perhaps other mental health challenges, and that didn't seem right. And back at the time, the employers were saying, well, they probably go to EAP. You won't see that in the claims data. At that point, people were getting maybe 3 visits, with EAP. So even if they were getting something through EAP, it wasn't specific to cancer, and it was probably very minimal at best. People did not understand their benefits. Some of our employers had oncology nurse management programs. Nobody was accessing them. But because what would happen, the claims process was the trigger mechanism for the health plan to connect to the oncology nurse manager to the patient. And if that person is 3 months into their cancer treatment and they're getting a call from the health plan, and so imagine this is 10 plus years ago. You can see the caller ID and it says health plan. They're not picking it up. They think it's about bills that need to be paid. And if they did pick up the phone, the person on the other end said, hi, I'm here to help you. And they've already been through the majority of what they would have needed help with. So it really was a really distressing for the employers. And then another factor is we were kind of at a point, I would say almost a tipping point, where cancer was not being addressed, touched. It was very hands-off by employers. And employees didn't want to share that they had the diagnosis. So we really had to talk about the privacy factor and how could we work around that. So there were a lot of things swirling around that led us to be able to say there's a lot of need for guidance in this space. So next 2 slides are what we call the placemat. This is basically the cover page to get into the employer guide. And that's what I was asking Diana about at the front end of the call. It's a PDF. And this first page is just kind of what it's about, things I've already talked to you about. But we had at MBGH and Florida Alliance some employer members who were our right-hand folks in helping us to put this guide together, and their names are down on the bottom left. I won't read those, but we also polled all of our employer members from both coalitions, and you can see in the employer guide the results of those surveys and different insights that came up. You can also see that our sponsors for developing the employer guide were Genentech, Merck, and Pfizer. And as Marianne said, we can't do our work without their support. So wanted to point that out. Next slide, please, is the second page. And this is the entry point into the microsite, the website that is actually the employer guide. But this is a visual for you. There are 7 sections in this employer guide. They are not, like necessarily, 1 and then 2 and then 3, because paying for care is in spot 7. You're paying for care from the get-go. Survivorship that I'll be talking about today. Survivors are defined as once that cancer is diagnosed. So that would be up at the front end. These are just content sections. And so you can see we had cancer prevention, screening, diagnosis, treatment, navigation, today, survivorship and return to work, and paying for care. So also on this page, in like the blue box, it shows the type of insights that we have in the microsite with this little light bulb that would delineate that that's an insight. You can either use the QR code, or when you get this physical copy, you can click on that link in the yellowy orange box, and it goes in to this website. And it was Chris Skizak who said, Karen, what are you going to do to keep this evergreen? We are working very hard to find funding to continue to keep disseminating what we're doing, but also to continually look at resources to see if they're better than what we have or if they're updated. Cancer, new treatments and things happen all the time, but also to surface employer stories and insights. We want to be able to get more of those in. So I'm hoping that between the two wonderful coalitions in Texas, that we are able to add some additional information in from all of you. So next slide, please. So at the in-person events, we really focused as we were trying to race through the 7 content sections, and a couple hours wasn't enough. So we really got as far as prevention, screening, and early diagnosis. And the big takeaway here is that, we've really got to get screening rates up big time, because there is later and later stage diagnosis of cancer, and that costs more, and outcomes are less likely to be favorable. So that was a big takeaway in there. Something that folks were surprised to learn was about the tie between cancer and vaccinations. And the HPV vaccine prevents many cancers, not just in women, but also in men. And also the Hep B vaccine can help reduce the risk for liver cancer. So those were, sort of important points, and there's detail in the employer guide about that. Also, a lot of the coalitions have been focusing on weight management and obesity for the last, handful of years. And there are about 30 cancers that have overweight and obesity as risk factors. So what we shared was, if you've got a strategy for obesity, for weight management, that's also a cancer prevention strategy. Next slide, please. So as I said, early identification of cancer. So some challenges. Not every cancer has a routine screening available for it. So not only do we have low screening rates, only 14%, as you can see in that middle section, of cancers are detected through a preventive screening. But all told, only 30% do. So we talked about multi-cancer early detection tests. They are not yet approved by the FDA, but there are employers who have decided to pay the $900 and some for certain subpopulations to be able to have these tests if they have, any family history or whatever the criteria. So more information on that is in the employer guide. Next slide. So then last month we talked about navigation and care management, and also really got into the medical cancer treatment, but also the psychosocial support to be provided, including hospice and palliative care. I won't go too much into that because I'll pick up on that later. Next slide. There's so many different terms for navigation, care management, case management, advocacy. There's a lot of overlap. So we defined care management. Typically, these are the nurses who are helping with managing the patient's care, making sure they're getting the exact right treatment at the right place. They can help advocate and do financial, but they tend to really be about the medical management. And we talked about that a lot in different case studies in that session. Navigators tend more to be social workers than nurses. And this is where the social determinants of health, being able to find financial resources got pulled in, because the cancer patient does not need to get bogged down by all these other issues that are preventing them from accessing the great benefits that you provide, from accessing the wonderful resources you have in your communities and in your regions. And it is a big piece of the delays for treatment, and also just lack of treatment happening. Next slide. So I always do a plug for the National Comprehensive Cancer Network patient guides. The images that are on this slide show some of the, I know there's hundreds. I should have counted up how many there are. There's so many of these for very specific cancers, and they are for patients, and they are phenomenal. And they are available. There's a link here online, free. You can print these PDFs, or you can go on Amazon and you can purchase a book for like $12 or $15. They range in price. And every single person who we have given one of these to, whether that's as a caregiver or as a patient, has said, I don't know what I would have done without it. It explains every step of the way in signs and symptoms and diagnosis and treatment and questions you should ask your care team. They're phenomenal. So what we have stressed every single time is employers, educate your plan members about this resource. Everybody knows somebody going through cancer, unfortunately. So also cancercare.org has a wonderful website. So these are self-navigation tools. So I wanted to do a plug for those again. Next slide, please. So we talked endlessly about making sure that the right care is being provided and how valuable biomarker testing is. And I know, the coalitions, most of them across the country, have been educating about biomarker testing. We have very specific guidance in this website about questions to go back and ask your carrier, because most of them are not staying up to date on the biomarker tests that have been developed and approved. And there's also a lot of delays with prior auth. So please go in, and if you weren't on any of the prior events, there's some great resources there. We talked a bit about artificial intelligence. People are a little nervous about AI, and there was a lot happening, to make it seem like it was a bad thing. But we talked about how it really does help the providers to be able to assimilate a tremendous amount of information, and it has been shown in most cases to really reduce that misdiagnosis that I mentioned, or the referral to treatment that isn't evidence-based best practice or NCCN standards. Talked about the importance of second opinion programs. Employers, most have them, very underutilized, to acknowledge and understand that patients aren't really into second opinions for a lot of reasons. They are worried they're going to have to pay more. They're worried it's going to delay care, and they're worried that they're going to upset this oncologist who they have met with, who they now want to help, save their life. So we had some guidance there on how to promote second opinion programs, and there are some that can happen in the background and don't delay care. So just another plug for checking that out. And then lastly, as I mentioned, we talked about how important psychosocial support is, mental health counseling, but there's a lot of confusion about palliative care versus hospice services. A lot of people think that when palliative care is being mentioned, that means that they don't have a chance to survive, that they can't have any more treatment, and that's not true. It is any stage of the disease. It can happen while curative treatment is happening. But similarly to hospice, where typically the prognosis is you only have 6 months or less to survive at this point, and you aren't in active treatment, they both provide comfort care, reduce stress. They're looking at pain management. So there's a great resource from Catalyst for Payment Reform on sort of best practice for employer benefit design. All right, so that's all the things we covered before. I'm going to take a drink of water and jump into today. I'm going to stop actually. Are there any questions yet, or anything? I don't see anything in the chat. All right.
No question.
Okay, great. Thanks. All right. So survivorship, return to work, and paying for care. Next slide, please. So what is survivorship and why do you need to know about it? Cancer survivors now, this definition are people living with cancer. They're in treatment. And it's also those who are through their treatment and they're cancer free. So what we learned during this process was a person with cancer is a survivor starting at the time of diagnosis. So during their treatment, right after treatment, and through the balance of their life. So so there has always been a little bit of confusion about that, but we learned from the oncologists they've got to start talking to that patient from the get-go about survival. So we're seeing that the people are getting through their cancer treatment and they are living longer. So it's estimated by 2040 that we're going to have 26.1 million cancer survivors in the United States. And they are not without ongoing needs. And so that's the more important part of this discussion. So let's go on to the next slide. So for those who are free of cancer, it's really important that they work with their care team to plan survivorship care. And you know, again, that needs to start at the front end. But once they're through that treatment, they've got to continue to focus on healthy living is a big part of survivorship. They may still have physical or mental health related issues that didn't resolve themselves through and after their treatment. They might have a weakened immune system. They might have some cognitive issues, neuropathy. Some folks have possibly lost a limb. So there's a lot of different issues that need to be addressed. Right after treatment, people are in very bad physical shape. They're maybe had atrophy. They're, excuse me, may have lost a lot of weight. So it's all part of that. So we want to make sure that they're getting the mental health support, that they're getting the ongoing physical needs addressed. A lot of survivors don't stay up to date on their vaccinations. They're worried. They maybe have read something online about how they shouldn't continue to have immunizations. So they need to work with their primary care provider and their oncologist to tell them what's safe and when they should have them. So not getting flu vaccines, not getting pneumonia vaccines. So those are the types of things that are covered there. From, you know, and again, back to NCCN and these patient guides, there are a couple on survivorship care that are also terrific. And they cover all of these different areas of focus. So let's go to the next slide. Sorry, I'm losing my voice already. That can't be good. There are additional survivorship resources that we have in the guide. Pfizer has a This is Living with Cancer program that is really excellent. It's a website and it has by cancer type, after diagnosis, what you can expect, really being able to understand the cancer diagnosis that you have, what you can do to stay strong, to stay as healthy as possible. They also have like patient stories that are and videos that are very compelling. And one of the things that they added, and I've been neglected to say all the way along on this particular webinar, is caregivers. And so caregiver support. And we did cover that in the last presentation. And there was really great work that was done by the Northeast Business Group on Health on caregiver support that we referenced, and they have done a lot of really, really good work, NEBGH. They also did one on cancer survivorship, and that's the second one that is referenced. They do something called a flipping book. So what you do, it kind of like turns pages virtually and takes you through all of the different stages of survivorship. The part of survivorship I haven't talked about yet, though, is the part where, folks are working, they're in treatment, they want to return to work, and that's a big piece of survivorship as well. And I'm going to get into that after we just stop here on the next slide and see if we can have some discussion about whether any of you have been proactive in the survivorship space. Have you done anything unique? Do any of the carriers or any of your solution providers do anything to help with this? So you can, I guess, Diana, tell me, they're going to do it in the chat? Are they going to raise their hand? How do you want to do this? Okay, Daisy, I see you have Access Hope through Blue Cross Blue Shield. That's great. We definitely talked about Access Hope, but would you be comfortable with unmuting and talking about your experience with them? That's a great program.
Yes, everyone's
Sure.
able to unmute. If you have a question or want to make a comment, you can raise your hand and we'll call on you.
Sure. So, Access Hope, we have that through Blue Cross Blue Shield through their health advocacy program. So it's something that you get automatically when you have their health advocacy program turned on. So currently, we don't have though cancers are number one, we don't have a lot of utilization because employees would have to engage first, right? They would have to go to Access Help and go through the program. So what I'm doing this year during our annual enrollment, we're creating a podcast, and one of the topics is cancer. And so we're going to have a representative from Access Hope talk about the program and what employees need to do to access the program.
And what kind of services for folks who might not know what that is?
Yeah, so what that is, it's basically a resource to help with cancer. It's a support program for employees and families. And so there's other programs that you can pay additional if you want to pay additional for, an expert panel. But really what we have with Blue Cross Blue Shield is a support program for employees and families.
Okay, great. Thanks. Does anybody else work with Access Hope who's on? Any ways to be able to increase utilization? Any ideas? Because that is a big challenge. We find that with not just with cancer, but with a lot of the great programs that you all, offer. Folks just don't know where they're, what benefits they have. And so in the navigation conversation that we had last month, we talked a lot about how having, a navigator or having, some way for, the employees to basically raise their hand, voluntarily and say, hey, I've got cancer, can you help me? And then get plugged in. And we did a cancer navigation program in Florida with the Patient Advocate Foundation, and they were able to we had a campaign where we said, if you or a loved one has been diagnosed with cancer, call this number to learn about your benefits. And people immediately responded to that. So, anybody else? Chris or Mary Ann, do you know of any of your employer members who might have done something in this space?
Well, no, actually, I can't think of any right now, but I'm going to go and check some of my notes to see. Thanks for checking.
Yeah, no, it's not something that comes up a lot. Okay, well, let me see. I see a comment. Do you want to unmute and share your survivorship visit information? Oh, it's interesting. So you're a provider.
Yes, we're an
Oh, it's
oncology.
Barry. Hi, Barry.
How are you? We're an oncology
As I
provider.
heard your voice, I know who this is.
And we actually have a planned survivorship visit. I'm sure a lot of places do. I don't know, but I know we do. Planned survivorship visit with patients. We try and do that when they move into what we call their 3-month follow-up, meaning they're through therapy um, and we go through, here's all the treatment you received. Um, uh, Tell us what questions you have or what issues you might have. We then talk about what your surveillance schedule is, meaning that
Good.
what you should be looking for or when your scans should happen and what to do if anything arises in between that time. And we also it's actually done with any one of our advanced practitioners in our organization. That's who does the survivorship visit. We also then ask about needs for the family or needs for them for psychosocial support or if they need to talk to our dietitian because they've gained so much weight from steroid usage
Right.
during the process. Uh, any of the or if they need to plug into a support group that we're aware of, or do they maybe have ongoing neuropathy and really need to try and want to try some sort of complementary therapy. We have access to some of that and we can get them connected to that. So we have a lot of conversation about just the social and psychosocial things that they need as well. And then, plug them in as needed. I will say a lot of it's an effort to get a patient to come in for a survivorship visit.
Yes. Yeah. I'm gonna ask
And
you that.
yeah, it's an effort on just getting them to come. So we've done a lot of them telemedicine wise so that we don't lose the opportunity to at least have the conversation. And that's helped a lot because a lot of times once they finish therapy, they don't want to come back for another visit unless they're forced to as a follow-up process. Survivorship visits to us are incredibly important because it does educate the person on what the surveillance schedule is and some of the things that they need to be aware of. But it's been a struggle to get people in for it. But telemedicine has helped us a lot.
Okay. Thanks so much. I have so many questions for you because um so
A big thank you, Barry.
the fact that it's hard to get them to come in, I have heard that. And so that's why we have said to the employers, educate about the importance of survivorship because what we saw in the data was that folks were not doing the ongoing surveillance. When they were done, they were done. And they said, if I ever get cancer again, because we did some focus groups, I'm never going through this again. And it was kind of horrifying all the way around because you thought, you know, you've just gone through this and you've survived and your family and work and all of that. Don't give up. We care about you. So there's so many different reactions when folks were just saying, I'm just not going to continue to get scans. When I have done it, my anxiety level has been very high in the lead up to it, and then, waiting for the results. So I wanted to ask you, you said that you do this after they've completed their therapy. The idea that you start the survivorship conversation right away, do you think that would help, Barry?
The problem we've done because our clinicians initially were pushing us on that, and that a lot of the general thought process is that survivorship starts on the first day of treatment.
Right.
The problem is you can't get people. The problem we face, patients were so engulfed in the treatment process. It was such a major overhaul to their lives that trying to talk about survivorship when we're just trying to get them through the anti-emetic medication they need to take,
Right.
and the pain medication, and what are they going to do about this, and how do they do that, and when they've lost their hair, and what do they do? There's so many things of just dealing with the treatment process. Uh, we just didn't have any luck with it at all.
Yeah.
So
So
we
it's easier
decided
said than done. And
easier
because,
said than done.
yeah,
We
because we definitely have heard from the providers, it needs to start on day one, over and over. You go to all of the meetings, and I wondered, how do you have that parallel track of, getting through all that treatment entails, and talking about survivorship at the same time. So
It just wasn't a
yeah.
reality for.
Yeah, so maybe that's something we need to put our heads together on and come up with. Is there anything that you see that employers need to do with benefit design or outreach, from your perspective, to be able to, encourage going to that visit? I'm assuming there's not coverage issues, but I don't want to assume incorrectly.
Sure,
Any
no,
thoughts?
there's no coverage issues. It's been like any kind of other visit, so we've never had a coverage issue. Um, and and it's not our inability to do it. It's just the unwillingness of the patient to really get engaged in that when they've been through treatment. Now, and we have all ends of the spectrum. We have some patients that they want to know every detail, and they're super freaked about anything that might happen, and so they want to understand their surveillance schedule. I will say telemedicine has helped, and the coverage of telemedicine has helped our ability to get access to survivorship visits to patients significantly.
That's a
Significantly.
great insight, and something that we haven't heard in all of the conversations that we've had so far, to be able to add in to this, because, I mean, obviously telemedicine became much more of a thing because of COVID, but there's still a lot of gaps and a lot of people who don't even know they have telemedicine anymore. So to be able to incorporate it into the employer guide makes a lot of sense. And if you've had success with it. So Barry, I'm going to chase you down and get more information on that.
Sure.
Thanks. Anybody else? All right. Well, let's go on to return to work. So, so this was really kind of a big area for us, because you had the people who wanted to return to work during treatment, and then obviously people, once they're through treatment, to get back to work. And where the employers were a little bit struggling was, not everybody wants to divulge that they have just, they're undergoing cancer treatment. They've just had cancer treatment, because they really worry. They're uncertain about disclosing their condition, because they're, worried about their job security, or that people will think that they're incapable of carrying out their job. So we talked a lot about creating a culture of safety and inclusion, kind of running in the background. But we also knew that physicians were really kind of changing their recommendations from past years about patients working while they're undergoing cancer treatment. So to encourage it, because there's data that says, that patients who can return to work during treatment, whether that's full-time or part-time, have better clinical outcomes. So there was a really good, reason for getting folks back doing something, getting their minds off of their cancer treatment, helping them to be less worried about the financial stress of not working, because that adversely impacts outcomes. And, when we did the focus groups, the people who were part of that, who were cancer survivors, said, I needed to go back to work for the money, but my friends are at work, and I needed to, kind of get back to something more normal. And there are a lot of reasons for why this is, a good thing. And for businesses, that helps because it's very expensive to replace folks while they're out. It kind of tends to be long tenured, highly skilled, and deeply committed staff who who have been diagnosed with cancer. But this doesn't come without, you know, accommodations that need to be made. Because and they maybe continue to need those accommodations, not just at the front end of where they're when they're coming back to work. So what we talked about was, how do you make those accommodations? How do you open up and have a culture where people feel comfortable being able to go to HR or go to their manager and their supervisor and say, I want to come back, but I'm going to need to come in part-time. I'm going to need to work virtually. I can do this aspect of my job, but I can't do that aspect of my job. So next slide, please. So there's also employment laws where that, rose to the surface, where people with cancer might face discrimination in the workplace because people are assuming they can't do their jobs. So, to be mindful of that. But being able to adopt or enhance a survivorship return to work policy that has guidance for managers and supervisors is really the big takeaway. We need to be able to make sure that managers and supervisors have been trained on how to have conversations, empathetic, very clear, but also to know all of the benefits and the resources. Because we have found that not just with cancer, but with other chronic conditions, that managers and supervisors really, they're a trusted source to most employees. And if they really understand the benefits that are available, they can help direct people to the type of care that they need. So this really goes beyond, compliance with employment law, and it really shows real leadership when you can create this workplace culture where they're, encouraged to know that when they return to work, they're going to be supported, and we'll come up with whatever the adaptations need to be to help them to get through their care, but also to be able to be, an important part of the company and contributing. Let me go on to the next slide. So the ADA, just it's really important to point out that the employee's right to equal employment opportunities is protected by the ADA. And so we talked about, what is a reasonable accommodation that isn't an undue hardship for the company. And that is going to vary very much from case to case and employer to employer. So there were a lot of our employer members who said that's their legal team that they go to when something that is an accommodation seems like it's really, out of scope. So we're not attorneys, so we don't, provide that kind of guidance. But we did talk about how important it is that, very clear about what the company sick leave policy is and paid time off. This is how you go through the state disability process and, family leave and federal. But to also point out, the EAP program. A lot of folks don't know what that is. I was on a call probably a year or so ago with a very large school district, and it was to educate the supervisors and the managers on mental health and well-being resources. And the person who was presenting, and there were 600 people on this webinar, starts talking about EAP, and he didn't say employee assistance programs. He didn't, he just kept going. And all these people in the chat were saying, what's EAP? What's EAP? I don't know what this is. So they had to just stop and do a 101 on EAP. So just to be cognizant of the fact that there are folks who just aren't aware. And then there's always the mental health and well-being resources. And as I mentioned, for cancer patients, when we find that they're not accessing those services when we know they need them, to be able, and the caregivers as well, to be able to manage their stress and their anxiety. What also the employer can do is work with the employee to develop a work plan, find out what those accommodations are, and then, if it's something that's easy, like working from home, or working maybe different hours and having time off to go get treatment, that's typically, a reasonable accommodation. So, next slide, please. All right, so does anybody have a return to work strategy, policy, any stories they can tell about how that's worked out? No. We have some model policies in the website in the employer guide. Oh, all right, well then why don't I go on to paying for care, since that's a biggie. So, what we talked about is what are the things that employers can do to reduce costs, or at least to maintain the level of spending and not have it go up for themselves, but also for their plan members. Okay, wait a minute. I see something popped up. It's Daisy again. You have partial disability through your short term, and I've been surprised that many cancer patients do like to work part-time. Now I know why. Okay, great. All right, thanks. Appreciate your sharing that. Okay, so, it's a balance of saving money, but also making sure that you're not cutting services, that it's high quality care, better outcomes. Obviously you want to keep your employees. You don't need to reduce access to reduce cost. You need to be able to look and see ways to remove waste. And I know both Texas coalitions have done a lot of work on, getting your data so that you can look at it and see what's going on there. So we won't cover that, but steering to high value care, and supporting your employees with the tools they need to be able to, make the best decisions that they have. So let me go to the next slide. A number of the things that we talked about in the earlier webinars are also ways to better manage your oncology spend. So early detection and prevention. So we've already talked about this on the front end, but enhanced screening benefits. So Rosa Novo with Miami-Dade County Public Schools came with me to the in-person meetings we had in Houston and Dallas. And she shared that not only is it zero cost to her employees or to her plan members for their screening mammogram, but they also do zero out of pocket for diagnostic mammograms, because she said there are so many of their female workforce who have been told they have dense breasts, and they every time need to go on to an ultrasound or a technology beyond just the routine mammogram. And she found that people weren't going to get a mammogram because they said, I'm going to have to go to the next level and I don't have money to pay for that. So she saw a tremendous increase in uptake of screening, but also did on-site with screening with a mobile mammogram as well. She also shared that with colonoscopies, folks would go, whether that was there every 10 years or if they were high risk or, family history, whatever it is. Once you are under anesthesia, if the GI doc finds a polyp, they're going to go in and remove it. That stops it being a screening colonoscopy. And you wind up, you wake up and they say they found a polyp and they removed it, and they tell you how much you're going to have to pay when you thought this was going to be free with no out of pocket. So Rosa also shared that it's no out of pocket when it gets to that point. So nobody's going to wake up and have to pay a bill. And again, saw the rates go up because that was something that had happened to so many people before. And like, I don't have the money to pay for that. So that's a way to, yes, you're going to pay a little bit more on the front end, but you're going to up your screening rates for breast cancer and for colon cancer. And if there is cancer, you're going to find it earlier and it's going to cost less. So it is a little more on the front end, but the long-term play is a cost savings. So I saw something come up in the chat. What have we got here? Is anyone familiar with BEXA? Chris, you want to ask your question and see? I don't know what that is.
Yes, BEXA is a revolutionary tool that is being used for breast cancer screening. It is not a mammogram, it's breast cancer screening, and is particularly helpful for those with dense breast tissue. We're going to be talking about this a little bit at our program in September, and I'm trying to gain some intel on it. I know one of our members is interested in it, but it's the nice thing about it is you do not have to to go to a clinic to receive that screening, and you do a clinic and apparently an ultrasound and one-stop shopping. I can't talk real intelligently on it at this point because I'm still learning about it.
Okay.
So that is why I wanted to ask that question. It's been on the market for a bit, for I guess a few years, but I don't know about it, and it's marketed, excuse me, as as a revolutionary breakthrough in screening. And it's not so much that it will, when they talk about it, of replacing those who are adherent to their regular mammogram screenings, but it will engage those who are not. And clinical accuracy, discovery of masses as small as 5 millimeter, 100% ultrasound classification, 2% false positive rate, 98% specificity. And it's a tool. It's high resolution elastography and a sensor to array to identify abnormal masses and combine with POC breast ultrasound. So anyway, I'm just learning about
I haven't heard about it, but I can certainly ask if any of our folks, I've got a few who, kind of get out in front, of, before things are,
I'll send the information to you, but it's my thought when I first heard about it, as this will be an evergreen type of document. It's one thing that might be added to it at some time in the future.
Yeah. Did you see what Barry wrote in the chat? Or Barry, you want to unmute and
Sure. Yeah, this actually came up in most recently in the last month or two, because of the BEXA folks had been around to some of the employers and they were calling us. So we don't do mammography. We would send it out, right? Or breast MRI. So we don't have a sort of a duck in the hunt, as they call it. But so I went to our breast surgeons who, again, are the experts in this area, and unanimously, none of them thought that this yet is proven to be more effective, and they're not as comfortable depending on it as they would be mammography, or for those with dense breasts, MRI and subsequent follow-up ultrasound. So, because we were excited, maybe there's something we could do here, and doesn't require as much, capital and such as having an MRI or a mammography machine. It's simpler. It's smaller. You can do it in places, but none of the experts are yet checked off on it, and were adamant that they did not feel like that it would currently is something that they would feel comfortable moving forward in one direction or the other based on the information from Bexa.
That's very helpful to hear that. So again, just like I said, gathering intel right now.
Sure. No, I did the same. I was with you, Chris.
All right,
Uh,
we'll have to check it out. Laura, I see your question and I don't know the answer. You might not be able to, but I will see what I can find out and get back with you on that. All right, I'm taking a peek at the time here. And so I'm not going to get into too much more on this, but the more that you can do to prevent cancer and encourage, healthy lifestyle and folks not smoking and what have you, and be able to, okay, I see your chat back, Laura. Looking at your, claims data, we were talking also about, are folks even getting their screening data from their carrier, and to get it in a way where you can see where the gaps are is very, very important. So let me keep going because there's a lot more to talk about. Just another reminder that a way to save money is also through navigation and care coordination because of, as I said earlier, avoid unnecessary tests, ER visits, hospitalizations, but also encouraging the appropriate tests and hopefully encouraging surveillance. As we heard from Barry, it doesn't sound like a lot of folks, want to make that appointment to be able to have a survivorship plan. So there are things that can be done to be able to, make sure that folks are getting the right care at the right time, at the right price. Second opinion programs. If people are spending 3 months on expensive care that wasn't the right care, that's a problem. So encourage those second opinion programs because every second counts for patients. They should be getting the right care at the right time, and you shouldn't be paying for care that is not appropriate. So that goes, back to the biomarker testing. So that's the next slide. There's a great action brief that Midwest Business Group on Health did on biomarker testing, and there was also the NCTA, National Cancer Treatment Alliance, biomarker employer checklist or toolkit. I guess it's toolkit that's in the guide. And, it's not just to determine the right care for a patient to be able to have, getting very specific, but it's also able to be used to measure whether treatment is working or not. So it really does allow the oncologist to practice precision medicine. And as I said a little while ago, carriers are covering some of it, but there's a lot of barriers that are in the way. So definitely refer to that action brief. Next slide. Same thing. MBGH does these great action briefs. They really put a lot of time and effort into them, and they're excellent. So they did one on paying for cell and gene therapies. It's all started, I remember, a handful of years back with, oh, you're going to see these, CAR T cell therapies, and they're going to cost over $1 million. Well, there's a lot of cell and gene therapies in the pike. The conversations are, really ramping up, at least for our folks, on how they could, possibly pay for care. We've had a lot of discussions, and you'll see in the guide, some folks have a stop loss coverage. They've looking at multiple employer risk pools. They're looking at paying for outcomes. We have one of the Jacksonville Fire and Police Trust that had a very special coverage for cell and gene therapies. It's still, you get one or two cases that require these, $2 million, $3 million, and not just cancer. Obviously, there are rare diseases as well, and it could really, really be a problem for your plan. So definitely look at that brief. It has some great guidance there.
Karen, I
Yes.
just want to add a reminder about our August 21st program, which is specifically on the CAR T cell and precision medicine. It should be really, really informative, just to give you more in-depth understanding of what you're talking about.
Great. Hey, I also see that we had some really good information in the chat. Starting next year, Daisy's saying you can cover diagnostic screening at 100%. This covers plans for high deductible health plans. So yeah, double check with your consultant, but that's great. Thank you for jumping in. That's good news. So the majority of the conversations that we had for paying for care are steerage, site of care, direct contracts, and so one of the things that really came up was everybody calls themselves a center of excellence. Like this whole cancer center is a center of excellence. The truth of the matter is they may be really good for a particular cancer, but they might not be as good on the outcome side for another. So this was, a really insightful to be able to break it down to that level, to be able to get data and information on who really is, the best at this particular type of cancer and has lower complication rates. So it's not easy work to do to get this data and to get this information, but we found folks who are just going with a whole, cancer organization, and they weren't the best at particular cancers, and they wound up having an arrangement for breast cancer here and colorectal there in the end. So but there are, without getting to that level of contracting, and again, going back to Rosa, she has been able to work with her plan to be able to move chemo and infusions that are being done in the hospital that were very, very costly out into the physician offices and infusion centers. They were costing her like 3 times more to be in the hospital than they were because of the facility fees. She had to also, they wanted to put the facility fees on the physician offices and infusion centers as well, but she was able to negotiate it to get those facility fees off, and it was much less expensive. We also shared in the earlier that Sherry Samuels First from Sargento Foods uses her on-site health centers for hydration, for for other services, and that was a big cost savings for her. She worked with the community oncology practice in the community to be able to have it delivered on site, and she was looking at infusions as well. So going back to, if you send somebody to an NCI designated cancer center and it's not in your hometown, really important to provide travel stipends to encourage the use of that center of excellence, because you want people going to the best place for the best outcomes, because in the end, it will be more cost effective for you. So there's a whole case study that Walmart did that involves their relationship with the Mayo Clinic. And that can also be found in the employer guide. Let's keep going because there's still a lot of things to do in 15 minutes here. So, value-based insurance design. There is not a lot happening with episode of care bundled payments. For all of the time and energy and effort that has been put into it over the years, because there are hundreds of different cancers, and it is very hard to be able to get enough patients with the particular cancer, with the particular provider to make it work. It doesn't mean that that isn't still happening and that we aren't still working on it, and we'll continue to share what we find. But Merck did a pilot program with a value-based insurance design that they shared at our event at Best of the Best and at some of the other coalitions, and they offered full coverage for screening at for five major cancers, and they directed their employees to oncology centers of excellence. They incorporated in the second opinion piece, even though they had this steerage. And they really were able to save money. They had great outcomes. So that story is also in the employer guide. So it is happening. You've got to align the incentives with those evidence-based treatment pathways in order for it to work. Specialty pharmacy. So a lot of folks were utilizing specialty pharmacies to make sure that that's how the cancer meds were being dispensed. And they tended to do a better job in terms of adherence for patients, and the costs were less. And as I mentioned about site of care and what Rosa had done, with shifting the infusions from the hospital, even the outpatient departments are very, very, expensive. When I said, they might even not be physically at the hospital itself, they still were putting these facility fees on. So to get to these independent practices is also much lower cost in the community oncology setting as well. So, there's a lot of things that can be done. Also, going back to reviewing your PBM contracts for spread pricing, for rebate guarantees, all of that is, helpful to managing oncology spend as well. The last piece that I'm going to talk about that came up during this whole process with these alternate, actually, if you could just go back right at the bottom of that slide, alternate funding programs. AFPs are really being promoted to employers, and we have employers who have picked these programs up, and they're promised really significant savings, especially for high-cost oncology medications. So the employers are like, oh, look, I'm saving all of this money, but now they're learning that there are problems that come along with them. So we can go to the next slide now. Thanks. So what are these? These have different names: specialty RX carve-outs, copay maximizers, copay accumulator programs. What they do is they shift the cost of some high-cost drugs off of the health plan. So you make people uninsured for that particular drug, and folks get sent to the patient assistance programs, to the manufacturer's assistance programs, to charitable foundations. So there's a third-party vendor, and those are the companies that are going to the employers, who says, okay, we're gonna, help the employees and help them apply for these programs. They're going to be free, or they're going to be subsidized. And then if it isn't approved, then you'd go back to the health plan and cover the drug. So it has become very, very complicated. Let me go to the next slide. So where the problems have come up is there's a lot of disruption for the patients, a lot of delays going through the process. They're getting denials because they might make too much money. There's a lot of very confusing paperwork because you've now become uninsured only for certain things when you have insurance for everything else. So we were hearing it was taking weeks and weeks. And so there's a big delay for these very important oncology meds being delivered. We found that there, in recent issues, immigration status became a problem in there. Or maybe they were on some nuance in the different plan offerings that the employer had. So a lot of patient disruption concerns. There's also some lawsuits going on, or at least there are threats of lawsuits, where they say, you're exploiting these charitable programs that were supposed to be for the legitimately uninsured, or very seriously underinsured. They were never intended to replace commercial coverage. So compliance concerns as well, using these programs in this way so that people appear uninsured can violate the program intent. So concerns with ERISA, HIPAA, and the Affordable Care Act. So this CMS is checking into this. So are a lot of the state insurance departments. So some of our members have done these programs and they're seeing significant savings, but now they have some buyer's remorse because of what they're hearing about the delays and the disruptions and the denials. Obviously concerned about legal and compliance as well. But what they've said was, I'm going to go to the CFO and say, we've got to stop this program, which has been saving a bunch of money. What can I replace it with? So that's kind of where we are right now. So we're working on this to try to find other ways to match what they're hearing is the savings. So that's my last slide on this. But so we've got this discussion thing. What are you doing to control cancer costs? But also, are any of you working with these alternative funding programs? And or if you're not working with them, what kind of drug savings programs do you have? Any kind of information you can share with us would be really helpful. This is a big area right now. I know Midwest Business Group on Health is also developing an action brief on it, as I understand it. So, any thoughts on that? Barry, are you seeing anything at your practice?
Yes.
Yes, I figured.
We, yeah, we've seen a couple of these, and it has been tremendous disruption for the patient. In many cases, because they do have insurance and these are just carve-outs, we can't actually access the free drug or drug support systems. Because they are intended in many cases for people who are uninsured or have financial issues. And so we've struggled a lot with this. In some cases, I know like 7-Eleven has one of these programs, and so in some cases we have been able to work out with 7-Eleven on a case-by-case basis. And so we'll go around the program basically because the patient needs to be treated, and the idea of trying to get free drug or whatever isn't going to work in many cases because of the decision for a specific carve-out. So we're trying to work with it. We're trying to work around it. But I will tell you, it does delay care. It takes time to get through this process with whoever the insurer is, or actually the third party, I should say, that and try to come to some conclusion on it.
Okay, thanks. Christy, do you want to go ahead and unmute and share the good stuff you have in the chat in case folks haven't seen it?
Sure, sure. Can you guys hear me okay?
Yes, great.
Okay, wonderful. No, I just wanted to, as we were talking about high cost drugs as it relates to cancer therapy, I just wanted to call out, as employers consider moving patients where appropriate back to independent community oncology, such as Barry's practice, wanted to highlight that they also have specialty pharmacy services. And so would love to be able to talk to the whole group about more of that in partnership with Barry. For example, he has 2 pharmacies integrated right into his practice. So what we've been seeing, and this is data from the health plans, is that when the pharmacist is a part of the care team, such as at Barry's practice, physician and pharmacy are working hand in hand, as well as you can see the medical record at the same time as the pharmacy record. And what that really means is, say, the pharmacy, Barry's Pharmacy, is going to dispense the medication. They can look in the EMR real time to see, say, if the patient has a scan scheduled and not dispense the medication, right, till after the scan, so you can see if the therapy is working, if the doctor's going to change it. And so it just is a real-time access issue. And there are many published studies out there too, everyone, to see like the speed to therapy, faster access for the patients out there, as well as increased satisfaction. Now, as you might know, I'm not saying this is a solution for every and all providers, because there just simply aren't enough community oncologists out there to sustain all the specialty oncology drugs. And so specialty pharmacy is still going to be needed, but where appropriate, definitely should be a consideration.
Thank you so much. Barry, do you want to add anything to that? Nice plug for you guys.
No, I know. I appreciate that, Christy. No, I just want to add that, as Christy mentioned, many times the dose needs to change or reduce, or we need to hold the medication, and we have the ability to do that in a real-time basis. That is not going to happen with specialty pharmacy because they don't have the access to the information or aren't connected to the care process. So in many cases, we can save money without having to delay care unnecessarily when it's needed, or go through, a subsequent negotiation process around some of these third-party guys. So, as Christy mentioned, we're not the do-all and die-all solution. But for those of you who have oncology practices in your communities, many of us can work with you on a lot of these issues, including this one. I also want to plug one more thing, and I'll say that I'm related to my practice, but in general related to palliative care, because super important to us, and you talked about that earlier. I go back to the telemedicine piece. We have an internal palliative care service, meaning we have a palliative care team inside of our practice. Their ability to actually work with the patient, we call it quality of life, not palliative care, but to work with the patient is significantly enhanced because we're able to do it telemedicine wise. There was an insurer, Aetna, actually, that was trying to do away with telemedicine, and I actually talked to their national medical director and said, you will hurt palliative care dramatically. Those patients are the ones that feel like crap, don't want to drive in, and our ability to manage their pain and move them through the continuum through telemedicine, huge. So I just throw that plug out again for telemedicine specific to palliative care.
Yep, I hadn't heard of palliative care being delivered by telemedicine, but that makes a lot of sense. Keep people out of the ER in the hospital. So
Yes.
great. All right. Last slide is just a thank you and my contact information. And I think we're one minute over. So I know I just flew through a lot of things, but the details in the employer guide, I really appreciate all the input and the interaction today. I learned things that we'll incorporate in. So I turn it back to Mary Ann and Chris.
Well done, Karen. Thank you so very, very much. I took copious notes. I know everyone else who is on here also is taking notes. This has been just a wonderful educational opportunity for all of us. And so I so appreciate what you've done to bring this information, this guide, to employers across the country, not only your own coalition members, which are using it, I know, but the Midwest Business Group on Health that worked with you on this, and the other coalitions that have invited you to participate. So I know that Chris and I are just so grateful for your leadership.
Certainly my pleasure, and we want to keep making it better because we don't have all the answers. And as I said, I took notes too. I learned some things. So
I wanted to add just one quick comment because I know Mary Ann's going to do this. We're going to do this. All of this information, the decks, the recordings, the toolkits, the placemat, the NCCN guidelines, that is all going to be made available through our HPCH website under member resources. So it's not a one and done.
Yeah, and the same with ours. But here's one a task that I would like to tell all the participants in this webinar. Go check your data. Start with just looking at your data on cancer care and find out, you had on your slide, what are your top cost drivers, what types of cancer, and start with the prevention and carry it through with the management strategies that Karen talked about. The guide is going to be wonderful, just to follow the steps of the guide. You've covered everything, so thank you.
all right. Well, thank you so much for
Have a good rest of the day.
inviting me. Thanks. All right, take care. Bye-bye.
Yes, and thank you everyone for participating. We really appreciate your attention on this one. Go put it to work. Thank you. Have a good rest of the day.